On behalf of Boulder Community Health, it's my pleasure to introduce tonight's speakers, Dr. Scott Blois, cardiologist at Boulder Heart, and Liana Quinn, physician's assistants at Boulder Heart. So with no further ado, I will go ahead and invite our speakers up. Thanks so much.
Well, hello everyone, and welcome. Liana and I are excited to be here, and we're going to try to teach you a little bit about this important subject about congestive heart failure and talk about the promises. And this is an area that's growing and very treatable.
My name's Liana. I'm a physician assistant over at Boulder Heart, and I've been working with Dr. Blois here since 2015 at Boulder Heart and treating congestive heart failure as well as some other comorbid conditions.
So maybe we'll bring up our slides if we could. So we just wanted to each do a little slide to tell you about ourselves, and then I'm going to step away and let Liana sort of do the first third of the talk. But I'm 56. I was born and raised in Northern California, and I went to medical school in Baylor College of Medicine in Houston, which had Dr. DeBakey and a lot of cardiology going on. I did my undergraduate at UCLA. I came up here to Colorado for sort of my first tour of duty in the 1990s, where I trained at the old medical school at 8th in Colorado. And then I headed to Austin, Texas, where I ran a heart failure clinic and was part of a transplant program in Austin for 15 years. But the love of Colorado lured me back, and I thought Boulder Community Health was very progressive and wanted to start their first heart failure clinic here in Boulder County, and I came up and started that in 2015. And over the last 8 years, we now have about 700 to 800 patients in our heart failure clinic, and we really emphasize co-management with the heart failure patients. We do a lot of teaching. There's a lot of information on the internet, some true and some not. And we really get you on the best state-of-the-art medicines and devices if needed.
I'm Liana. I'm a 31-year-old. I was born in New York, near the city, if anyone's familiar, in Rockland County. I went to grad school for physician assistant at SUNY Upstate Medical University in Syracuse, New York. I started my cardiology career in upstate New York at Saratoga Springs in general cardiology. I moved to Colorado, also lured by how beautiful it is out here, in February 2021, and started with Boulder Heart later on that year, December 2021. So since then, I've been working alongside Dr. Blois and our other providers to treat patients, a lot of patients with heart failure, as well as other cardiac conditions.
We were very lucky to get Liana. So just to go through what we're going to talk about, we're going to start with a little bit of a definition of heart failure and then talk a little bit about the growing prevalence of heart failure and the economic costs. Really try to teach you some of the signs and symptoms of heart failure and the leading causes of heart failure. And then if you really thought you might have heart failure, working with your internist or primary care doctor or general cardiologist, the tests we use to diagnose heart failure. And then we're going to talk about the treatments, both medically and pacemakers. And then lastly, in heart failure, there's a lot of lifestyle changes that need to happen and to really be just as successful besides being on the best of medicines, and then leave hopefully about 10 to 15 minutes at the end for questions. So I'm going to step away and let Liana take it from here.
Okay, thank you. I'm used to define a very common clinical syndrome which ensues when the heart is unable to pump enough blood to supply the metabolic needs of the body. Basically, the heart is not functioning as it should. We'll take a little tour of the heart so we understand what we're talking about when we talk about heart failure. Here we have a slide looking at the right side. It's as if we would cut the heart in half and then took the front half of the heart off. So we have the right atrium, the right ventricle. This collects used up deoxygenated blood and pumps that, the right ventricle will then pump that blood to the lungs to be oxygenated. That oxygenated blood will then come into your left atrium, be pushed into your left ventricle, which is your main pumping chamber of the heart. Left ventricle will then squeeze and push that blood out to the rest of the body through your aorta. The left ventricle is kind of the star of the show today, and what we focus on when we talk about heart failure would be dysfunction of that main pumping chamber. So we're going to talk about how prevalent this disease is. 1 in 5 people will develop heart failure in their lifetime. There's about 5 million diagnosed cases of heart failure. However, that represents probably about half of the total true cases of heart failure. There are maybe 5 to 6 million people walking around with asymptomatic heart failure or heart weakening. There will be over 500,000 new cases a year of heart failure in the United States and over 250,000 deaths of heart failure a year. So with such a prevalent cardiac condition, there's also a high cost. And we can see the cost increasing over the years. In 1998, the total heart failure cost was about $20 billion. That increased to about $32 billion in 2014. And by 2030, the total heart failure cost is thought to be close to $72 billion. This is the most costly heart disease in the United States. When we think of heart disease, we think of heart attacks and bypass and stents, but we have people now surviving their heart attacks with some excellent care that we are now able to provide, and so people are living longer to develop heart failure later on. If someone is diagnosed with heart failure and then has a heart failure exacerbation requiring a hospitalization and treatment, that average length of stay in the hospital will be about 5 days, and that cost can be around $30,000 to $40,000 per hospitalization. This is a slide kind of just visualizing the projected increase in heart failure in our population from 1950 all the way into the future of 2050. Dr. Blois called this his job insurance. So we'll talk about some of the symptoms we'd want to think about if potentially you have heart failure. Symptoms of heart failure are often confused or mistaken for kind of general aging sometimes, and so it's important to pay attention to these different symptoms that may actually represent heart failure. So we'll use an acronym called FACES, F-A-C-E-S. We'll start with F, which would be fatigue, mostly with exertion. However, later stages, you can have fatigue just at rest. You can see how this might be misconstrued for just a sign of aging as well. Activities limited. This could be as simple as you are no longer taking the stairs because for some reason it is more difficult for you now, whether it's shortness of breath or something else limiting you, and you are now using the escalator, or even activities of daily living becoming more difficult. Chest congestion for C would be fluid building up in the lungs, a cough, and congestion within the chest. On that same note, edema or ankle swelling would be fluid buildup in the legs and ankles, sometimes associated with some weight gain. And S would be shortness of breath, usually with exertion, but can also be associated with rest if there's later stage of heart failure present. We'd also want to look out for shortness of breath at night, especially when laying down flat, finding that you need to sit upright in order to breathe, or waking up with a gasping feeling. Again, it's very important to diagnose heart failure early. You'll have better prognosis and better treatment outcomes and responses if we're able to diagnose and treat as soon as possible. And unfortunately, heart failure can be misdiagnosed and mistaken for a number of other diseases because the symptoms are so general. So listed here would be asthma, or some common diseases that we mistake for heart failure. Would be asthma, pneumonia, upper respiratory infection, and even just some depression or general tiredness. So what are the causes of heart failure in the United States? Far and away, the coronary artery disease or heart attacks and decreased blood flow to the heart muscle would be the leading cause of heart failure. You can imagine if the blood flow to the heart is compromised in some way, that the heart is not getting what it needs to pump vigorously and would weaken over time. High blood pressure, especially uncontrolled high blood pressure and long-standing uncontrolled high blood pressure, will weaken the heart muscle. If the heart is pumping against a high-pressure system all the time, that will fatigue the heart eventually. Another source of heart failure would be this idiopathic source, this double hit theory, where someone has a family history of heart failure, and so they have this genetic predisposition, and then there's an insult of a viral illness or exposure that may not have caused someone else without that genetic predisposition to develop heart failure, but for them, because of their family history, we see a weakening of the heart muscle. Issues with valve function as well within the heart can cause heart failure, and some toxins such as alcohol, more than 2 drinks a day, can be cardiotoxic or toxic to the heart. These are some other conditions that can lead to heart failure. Up there we see ethanol or alcohol as a leading cause, cobalt as well. There's a strong prevalence of cocaine-induced heart failure and methamphetamine-induced heart failure. We also have to think of some metabolic abnormalities and endocrine disorders such as hypothyroidism or anemia as well. And then some infections and viral infections like HIV and some of the other infections listed there. So if someone comes to our clinic and we are concerned that this person may have heart failure, you can expect to have some tests done preliminary to see if this is indeed heart failure that we're dealing with. So we'll start with an EKG usually, or ECG, which is an electrocardiogram or an assessment of the rhythms of the heart and the electrical system within the heart. This can tell us if there's been some hypertrophy or thickening of the heart muscle, which can be resulted with high blood pressure. It can tell us if there is some evidence of a previous heart attack or if the conduction system within the heart has slowed or changed for some reason. We'll grab labs to look for anemia as a cause for heart failure. We'll look at your kidney function, liver function, and thyroid function. A chest x-ray will be also an important part of your workup, as this will look for any fluid in the lung fields that may lead to congestion and that cough that we talked about before. Then we'll get into the more specific cardiac testing, specifically an echocardiogram and something called a brain natriuretic peptide level, which is a blood test. So an echocardiogram is a sonogram of your heart that gives us excellent information about how well your heart is pumping, how well your heart is structured and functioning. We take measurements of your valves and the sizes and shapes of your chambers. So this will tell us if that left ventricle is not working properly, or if there's something structurally wrong within the heart. This test uses ultrasound in order to look at your heart, so there's no radiation involved. It is absolutely safe. A lab test called BNP is also a very important part of our diagnosis of heart failure. This is a protein made by the heart. The name has brain natriuretic peptide, but it was actually found to be made in the heart if there's been some strain or stretch on the heart muscle, especially in the left ventricle. It's considered to be abnormal if the value is above 400 on a lab test. An NT-proBNP is another test that may be ordered. It's a slightly different assay getting at the same diagnosis, and that one would be abnormal if the value is above 450. The test is very sensitive in that if it's positive, if you do have heart failure, it is likely to be positive at 90%. It's also very specific, meaning that if it is indeed elevated, it's 98% chance that indeed we are dealing with heart failure. However, there are some other diseases that we can see BNP elevation, specifically pulmonary diseases like COPD, pneumonia, blood clots in the lungs like pulmonary embolisms, chronic kidney disease. As age increases, the normal value for a BNP can also increase, especially above 85, and pulmonary hypertension can also cause an increase. So if we do diagnose someone with heart failure, we have to look at some more tests to find out why that might be. We said that coronary artery disease is the most common cause of heart failure. So we want to get an assessment of your coronary arteries. That's usually with a coronary angiogram or heart catheterization. And we'll look at we'll thread a catheter up through your wrist or through your groin up to the level of the heart. Then we get an assessment of the coronary arteries that feed the heart muscle and see if there's any plaque in those heart arteries that might be compromising blood flow. We'll also be able to take pressure readings within inside your heart to understand what volume or fluid overload might be like within the heart. We'll consider an MRI of the heart, potentially a stress test where we're walking or running on a treadmill, or potentially a resting stress test if needed. We'll get some more labs and consider some genetic testing. And Dr. Blois will take it from here to talk about the two types of heart failure.
Great job. Thank you.
Thank you.
Well, thank you, Liana. So we've now sort of learned a little bit about the symptoms, and then we've learned about the testing. So unfortunately, our testing has showed that we've got some weakening to the heart. And going back to that slide where she talked about the heart and the left ventricle, a left ventricle normally on each heartbeat for somebody who doesn't have any heart problems pumps around 50 to 70% of the blood out on each heartbeat. Nobody pumps 100% out. And we call that the ejection fraction of the heart. And that term I'll be using a lot in the next couple slides. So for heart failure, now that we say the heart is weakened, it's important that we sort of divide it into two types of heart failure you might hear us talk about. And one is called diastolic heart failure. And that's when the heart muscle is relatively normal. You haven't had a heart attack that's killed half the heart, but it's a problem more with relaxation in the heart. On each heartbeat, you want about a second for that heart to relax and for the heart to be able to refill and pump out. And somebody with diastolic heart failure, it's more of a relaxation inability to refill problem. And then systolic heart failure is when you actually see on the echo the heart has been weakened, and they really on each heartbeat they can't pump more than 40% of the blood out. There's sort of a mixed heart failure, which is when the heart's pumping somewhere around 41 to 49% of the blood out. So starting with diastolic heart failure, there's a lot of diseases that can make the heart get stiff. Probably the most common is hypertension. Atrial fibrillation can do it. Infiltrative processes. There's some diseases that will replace your normal heart muscle tissue with inert proteins. The most common is amyloidosis. Coronary artery disease and blood flow problems to the heart make the myocytes not relax well. And then unfortunately, just aging. We know that as you age, your heart gets stiff and fibrotic. In the past, really until about a year and a half ago, there wasn't clear drugs that on a double-blind randomized study, if you put somebody in placebo and you put somebody on a drug, showed that you could reduce the risk of dying. But now it's exciting because there's some drugs coming out in the class called SGLT inhibitors, which I'm going to talk a little bit more about their mechanisms, is one of the clear winners in taking care of diastolic dysfunction. Also, the ARNI agents, one of them is called Entresto, and the mineralocorticoid antagonist, but we're going to go through those. You want to treat the underlying cause the best it is. If it's caused by atrial fibrillation, trying to slow down the rate and get them back in normal. If it's uncontrolled high blood pressure, getting the blood pressure under control. And diastolic heart failure is probably more common as you get older than systolic heart failure. So greater than 50% of the population when you start to get over the age of 70 has diastolic heart failure. And this is just a slide showing the many, many different things that then can come in and cause heart failure. And going around the clock, you can have lung problems, you can have kidney problems, you can have hypertension problems, coronary problems, but everybody has this in their handout. But as you can see, there are probably 15 to 20 different things that can cause the heart to get stiff and cause heart failure. And one of the tasks from your cardiologist is to find out what it is and best treat it. Before we go on and talk about systolic heart failure, I want to talk a little bit about how we classify heart failure and why that's important. If you come to me, a lot of times in my clinic note, I will try to put in there what I think your classification is, how severe it is. Is it mild, moderate, severe, or really severe? And the New York Heart Association heart failure class, it's been around for 50 or 60 years, but it's still quite helpful. So to be in this classification, you have to have a test that shows your heart's not working well. And that's usually on an echo or on an elevated BNP level. A class 1 is your best prognosis. That's a person who we have an echo that shows their heart's pumping at 30%, but we walk them up Mount Sanitas and they don't get short of breath. They really don't have any signs of heart failure. Class 2 is slight limitations. These people can walk a mile and then start to get a little short of breath. In my clinic, coming from the lobby to my room is about 100 feet. There are people that get short of breath doing that, just walking down the hallway 100 feet. Those are class 3. And then a class 4 patient is somebody who just talking to you has to take a couple breaths because they're short of breath. About 10, 15 years ago, they created a second class called ABCD. And this was to sort of go upstream and start to identify people that are at risk of heart failure but don't have heart damage yet. Because we know that the earlier we can identify heart failure, even to the point of at risk, and get you on treatment, the better the prognosis. So class A is people who have hypertension, have coronary artery disease, plaque in their heart arteries, have diabetes, or have a family history of early heart failure, a member that's had heart failure in their 30s or 40s. They don't have heart failure yet, but we know that those are very, very at high risk. So that's called a class A. Class B is sort of like the New York Heart Association class 1. You've got heart weakening, but you're asymptomatic. Class C is sort of that class 2 to 3, and class D is like the class 4 where you're short of breath at rest. And why do I belabor this point? Well, this is some of the prognosis if you have this. So for example, that person that has trouble walking from my lobby down to my room is a class C. As you can see, they have about a 20% chance of dying per year. And they have, on average, they're hospitalized, where Liana said, for about 5 days for $40,000, 1 or 2 times a year. So this is a person, if you have heart failure and they're short of breath walking into your lobby, it's not somebody that you're going to say, I'll see you in 6 months. We need to really get on top of this fast because this prognosis can be dangerous. There's been some discussion both in the Wall Street Journal and other ones about heart failure and COVID. The first strains of COVID were more sort of virulent than the ones that are now. But we know that a person with chronic heart failure, if they get COVID, the infection is more dangerous. And that's just you don't have a lot of reserve in your heart. In general, at the beginning of COVID, there was about a 1% mortality in COVID if you had no medical problems. That's not the case now. The strains are less virulent. But in the early months of heart failure, of COVID in 2020, there was about a 10% mortality if you had significant heart failure and got COVID. So this is usually about halfway through the talk, and everybody is very, very depressed and down. And that's the bad news. But the reason I got into being a heart failure specialist is there's a lot of good news. So back before 1990, if you developed heart failure, your heart got weak, you were prone to fluid building up, we really had diuretics to give you, things like Lasix. We had digoxin. And actually, morphine's a very good medicine for getting rid of congestion in your lungs. But we really didn't have anything that could turn around the injury and get the heart stronger. So unless you got a heart transplant, your heart didn't get stronger. And if you really get on the internet and you look at mortality and studies before 1999, it's pretty scary. The survival for advanced heart failure was as bad as metastatic breast or lung cancer. But things changed in the 1990s. There was a lot of research put into heart failure, and we found that the heart responds very similar no matter how you're injured. And it turns on, right now at least we know, of 3 or 4 hormones that make the heart work harder. And these hormones come from the heart, they come from the kidneys, they come from the adrenal gland, they come from the vascular bed, and they sort of whip this struggling heart to keep working. And that hormone surge is not good. It makes the heart get weaker. So a lot of medicines were developed to block this hormone surge, which then actually, versus if you break your spinal cord, you're unfortunately paralyzed, the heart can regenerate. It can get stronger. And that's a really exciting, good thing to happen. So this just talks about when you, up at the top of the slide, for you hurt your heart, whether it's a heart attack, whether it's a virus attacking your heart, whether it's drinking greater than 2 glasses of alcohol a day for a long time, whether it's uncontrolled high blood pressure. And that box in the middle, you activate about 4 hormones in your body when your heart gets injured. One of them is your adrenaline level. a heart failure patient, if we take a vial of their blood, their adrenaline levels are usually about 8 to 10 times higher than a normal person's. There's a hormone that comes from the adrenal gland and kidneys called the renin-angiotensin system, which is activated. And then we know a lot of pro-inflammatory enzymes come out of the blood vessels when the heart gets injured. And all of these start to make the heart get weaker, and they actually, at a DNA level, start to make the heart create muscle fiber that doesn't work as well. And then it's a vicious cycle. The heart gets weaker, the hormones are activated more. So the big strategy is to block these hormone surges. So a little glossary of some of the medicines we're going to talk about. Beta blockers. Beta blockers are the medicines that work. You have a beta receptor in your heart cells, and adrenaline attaches to this beta receptor. And so beta blockers were developed to block this beta cell and let this high surge of adrenaline not hurt the heart. And then SGLT inhibitors, which we talked is probably the main new breakthrough in diastolic heart failure. You have SGL2 receptors in your kidney, which reabsorb sugar. So this is a medicine that was initially developed as a diabetes medicine. You block reabsorption of sugar. But in the testing and the safety trials, we found that it's been quite helpful in heart. Some of the mechanisms we don't know. Then the angiotensin receptor blockers block this renin-angiotensin surge that comes from your adrenal glands and kidneys. And then there are actually mineralocorticoid antagonists that block this hormone surge. The most common one we use is called spironolactone. So we call it the 4 pillars of heart failure treatment for systolic heart failure. And that's when that left ventricle can't pump more than 40% of the blood out. So really, and unfortunately, there isn't a magic bullet that can block all the hormones. And so you have to really educate your patient that you're going to be on about 4 to 7 medicines because we need all of them. All of them work in a different way. But you should be on a beta blocker. You should be on an SGL2 inhibitor. You should be on a mineralocorticoid inhibitor. And then you should be on some type of renin blocker. And this table shows that if you get on these, how much you'll bring down the risk of dying per year for each of those. And some of them, for example, if you get on a beta blocker, will decrease the risk of dying by about 34%. And so these heart failure, especially systolic heart failure, about 60 to 70% of people, the heart gets stronger. And this has become a very treatable disease that sort of becomes a chronic disease you're going to live with. And you don't die in the 2 to 5 years that you did before the 1990s.
I actually have, there have been a couple of questions that have come in. One of them is, what is the difference between, again, can you just roughly explain the difference between an electrocardiogram and an echocardiogram? They're different procedures.
So Liana started with sort of the most non-invasive, cheapest, simple tests we do to the really MRIs and heart caths and stents. An EKG is when we put electrodes on your chest and we get a piece of paper that shows your heartbeat. And somebody with heart failure, a lot of times we can see signs of heart failure. If we say that heart attacks is one of the leading causes, we can sometimes see signs on the EKG of a heart attack. And we can also see signs of heart arrhythmias and such. The echocardiogram is the same equipment that when a woman's pregnant, they do an ultrasound of the baby. You come in and we have a probe about the size of my thumb and we put a little gel on it. You take off your shirt and you get in a gown. It takes about 30 minutes and we put the probe on your chest and we bounce a sound wave about 7 inches down to your heart and it comes back, and on a computer we can see the heart beating and look at the strength of the heart, the valves.
I see. Okay then. So neither one are invasive.
No.
All right. So you may get to this, but is there a specific way to prevent a high level of BNP? Other than the lifestyle changes and the other things that you would do for a healthy heart in the first place?
We'll talk about that if we can get the slides back up.
Okay. All right. Good. And, is a weak heart, is this condition a hereditary condition? Typically, I mean, how much of that plays a role?
So I would say we're finding out more and more about hereditary risk, but right now I'd say 20 to 30% of the time heart failure is related to hereditary. There's other things that it can be. So we'll do genetic testing on about 20 to 30% of patients.
Excellent. Okay, a couple of questions are coming in while we're waiting. Well, this one, I think I can maybe guess your answer, but how big a risk factor how big a risk factor is previous alcohol abuse in a 78-year-old woman?
So alcohol, and we're going to talk about it on a coming up slide. There's sort of you can see some data that a glass of wine a day helps your cholesterol and heart. But we know that if you're drinking more than 1.5 glasses of alcohol a day, it can turn into a toxin to a lot of organs in your body, including your heart and liver. So I would say if you've had previous heavy drinking and you've stopped, you're probably doing okay. But if you really are drinking 2 or more glasses a day, that could be causing injury to your heart.
Thank you. Yes. What is your feeling about a coronary calcium scan test in helping to determine heart disease?
So this is a test that looks, it's a CAT scan that we use to see if there's any plaque forming in the heart arteries. You come in and there's no needles involved and you do a CAT scan. If you have plaque forming in the heart arteries, it usually comes across as speckles of calcium, so it can tell us if plaque is forming. I think it's a helpful test to do if you've got a person that you're on the fence about risk factors, how aggressively to treat. I use it a lot in the 40 to 50-year-old patient who's smoking, maybe borderline diabetic, borderline high cholesterol, to really see if plaque is forming in the heart. Should we be starting on meds, things like that. It's a lot of times a wake-up call when you see a CAT scan showing plaque.
I see. Our tech fellows working feverishly to figure out why we've lost our slides. So stay with us. And thanks for answering that about the calcium. With the 4 pillar drugs, should you take with meals or at particular time of day?
I think the pharmacist will know that better on that with each of those medicines. You'll have instructions on your bottle.
Wonderful, wonderful. Folks, go ahead and ask your questions if you have any, and we will just take those as we figure this tech issue out. Oh, I had a question. Let me see if I can grab it in my head. You mentioned that some people may have heart issues and not have any symptoms. Should you just get a regular EKG or some heart testing, even if you're not feeling any symptoms at a certain age? Or
I would say if you have risk factors for heart failure, even though you're asymptomatic, and that could be a family history of premature heart problems, or you're diabetic, or you're on blood pressure medicines, then I think an EKG would be helpful. And then sort of talking with your primary care doctor about, is there any suspicion for doing more advanced testing?
I see. Let's see. On the last visible screen, there was a column labeled NNT. What was that about again?
That's a number needed to treat. So usually when you do a study, besides looking at sort of statistically how the drug does it bring down the risk of being hospitalized with heart failure or dying, we also have to be cognizant that we have a finite amount of money in healthcare, and so we look for drugs that we have a low number to treat. So if you only needed to treat 10 people to save a life, that's a lot better than if you had to treat 1,000 people. So you're looking for a low number on the NNT is a good sign that it's a very effective drug or therapy.
Is there a safe number that you wouldn't need a statin after finding out your calcium score?
That's a little bit too vague of a question. Each person is a little bit different. I can't give you an answer for that.
Okay. I'm thinking out loud, a suggestion perhaps is for our viewers to download the lecture slides and then follow along, and you can look at the slides from this computer and you can read through the slides and people can follow along. So we'll give another couple minutes and we may try that. And that way the viewers can see the slides. Viewers can see the slides, and then you can also see your slides and can talk around that way. There is one more question though. What do you know about drinking beetroot juice?
Not a lot, unfortunately.
Yeah, I'm seeing a lot about that too, and I don't,
No,
I mean, I know boots are.
we do have a slide coming up if we can get to it on supplements a little bit. I don't have anything new hot data on beet juice.
Yes, that guest asked that question because she's doing a study with beet juice. Does having taken CA supplements for bone strength over many years end up causing CA plaque in arteries?
So when we say CA, I think we're talking about calcium. And we talked about calcium. We can pick it up on a scan to see cholesterol. And calcium in the heart in general is not a good thing. It doesn't correlate with taking calcium supplements. That doesn't seem to be a risk for coronary heart disease. And it's very important for treating your osteoporosis.
What does a heart pain at rest indicate when no pain during exercise?
It's something, if you're having chest pain, I think whether it's at rest or not, it's something that is abnormal, and you ought to see your primary care doctor and probably have an EKG to make sure things are okay. So it's something that should be evaluated by your doctor.
Very good. So let's suggest this. If I could ask our viewers if you'll scroll to the top of the screen, you'll see a blue button on the left-hand side of the screen that says View or Download Lecture Slides. If all of the viewers would click on that button, you'll find all of the lecture slides that Dr. Blois is presenting from. And at the same time, I'm going to offer the computer I'm looking at so that he can read from these slides, and when he says go to slide 4, everyone can look at slide 4, because I'm not so certain we're going to get our overhead projector to work. So if everyone would go to the top and download the PowerPoint slides that Dr. Blois is presenting from, and I'm going to make this big enough for him, and I think he can pick up where he left off at whatever slide that was and present from there. Or we could, I will see if, we may also wind up rescheduling this one, but let me check with my folks, but there we go. Where did we leave off? We left off in here somewhere. I believe it was, oh yeah, it's past.
Benefits of evidence-based, evidence therapies.
There it is. Okay.
All right, well, we'll try this, and I really do apologize. So we're on.
Yep, we're on slide 29. We'll pick up from there, and we'll keep you posted on the technical issues.
So slide 29, as we talked about, shows that if you get on each of these drugs, what your 1-year reduction in mortality is. So for example, being on a beta blocker reduces the risk of dying of systolic heart failure in a year at 34%. Slide 30 and 31 I'm going to skip just for time, and we were going to talk about slide 32, which just brings up the point that not only being on the right medicine is important, but actually being on the right dose. And this was a drug study that was done, if you look at the bottom on the slide, in 1996, when beta blockers were really starting to be developed for heart failure. And it shows that if you take the 6 milligram dose versus the 12 milligram dose versus the 25 milligram dose, the 25 milligram dose has your best chance of your heart getting stronger. So one of the things that we do in the heart failure clinic here at Boulder Heart is, besides getting you on the medicines, and your body's not really ready to take the 25 milligram dose right away, it'll cause your blood pressure to be too low and such, is we work on sort of seeing the patient every 3 to 4 weeks and getting the blood pressures up to the goal dose. So it's both being on medicines, but also at certain target doses. When COVID came out, there was concern about taking an ACE inhibitor or an angiotensin receptor blocker. And this was because they found that the SARS gene actually got into the cell at the ACE receptor. And there was some suggestion that if you took these medicines, you might have a more severe infection or such. And what they found was that that was not the case. That was sort of hypothetical, but actually you really shouldn't stop your heart failure medicines. And so if you get COVID, don't stop your ACE inhibitor or your angiotensin receptor blocker. There's a theoretical, but not really when we've looked at it. Other medications on slide 34 are diuretics. We talked about the heart gets weakened and you're more prone to fluid building up in your lungs or in your abdomen or in your legs. So we use diuretics a lot. This controls the congestion, the shortness of breath, and the swelling in the legs. Digoxin was a very important drug before 1990, but now probably less than 5 to 10% of the heart failure patients take it. There's a very narrow therapeutic window where it can become toxic. We still use it in some people who have AFib, and it helps the heart get stronger, but it doesn't do any of this blocking of the hormone surge that we really emphasized is what a good heart failure medicine should do. And then there's a combination of hydralazine and Iserdil that in the African American population has been shown to be quite helpful. So just slide 35 brings up one more time in diastolic heart failure that the SGLT2 inhibitors are probably a drug that you ought to talk to your doctor about being on. And then the other 3 would be ones promising also. Slide 36, we talk about supplements. And unfortunately, they've been studied and haven't been found to be that helpful, which has been frustrating. Omega-3 fatty acids are probably helpful in decreasing if you have a lot of heart attack problems or dementia. And coenzyme Q10, a lot of people use to mitigate the sort of toxicities of being on a statin. Multivitamin is helpful. If you're anemic, iron is helpful. If you're not anemic, iron has not been shown to be helpful. But beyond that, all the other supplements have been studied and at best are sort of neutral and at sometimes have been deleterious. And if you're already going to be on 4 to 7 prescription medicines, adding a whole bunch more supplements, you sort of become a soup of medicines, and the potential for adverse drug interactions gets higher. Slide 37, just as your muscle function of the heart can get weak, your electrical system can get weak. And so not everybody with heart failure, but I would say at least a third eventually need to have a pacemaker and or a defibrillator in. And that's just your heart electrical system can get slow and need to have a pacemaker to keep it going. We have special sort of modern biventricular pacemakers, which is when we see on the EKG your QRS interval is prolonged, and that's a sign that your left and right ventricle aren't working well, and you can have a biventricular pacemaker put in. And then lastly, we know that if even on best of medicines and echo shows your heart is not beating better than 35%, you're at risk of having arrhythmias that can start in the bottom of the heart called ventricular arrhythmias. And those can be potentially dangerous and deadly. And we have an AICD, which is a pacemaker with a shocking ability that if it detects you go into this arrhythmia dangerous that could kill you, it'll shock you out of it. Slide 38 talks a little bit about the 10% of heart failure patients that we can't control with medicines or AICDs and devices. About 90% of people in a heart failure clinic, we can stabilize and get better on medicines. About 10%, unfortunately, continue. And there are now, we don't do this here at Foothills, but if it comes to this, we have a good relationship with the medical school down in Anschutz, where we can send you, and they have a program, surgical program, where they put in mechanical hearts. And this has really been an advance. Going back 50 years ago, the first mechanical heart was about the size of a refrigerator, and the bearings in it lasted for about 5 days. And now on slide 38, you can see it's called a ventricular assist device, is actually can fit in my hand, and the bearings can last for 4 to 5 years. Slide 37 just talks a little bit, and I think we'll sort of finish up soon, about transplantation, and you can sort of read the next couple slides about transplantation. I want to finish up, if we go to slide 42, just to talk about risk factor modifications. If you have heart failure, it is important to both get on the right medicines, but also sit down and talk about some needed lifestyle modifications. And one of them, and we spend a lot of time in our clinic educating patients, and one, for example, a blood pressure in a heart failure patient is a very different goal number than somebody who doesn't have heart failure. The normal top systolic blood pressure patient is usually about 95 to 120. If you're 140, that's actually hypertensive for a struggling heart. So we learn to not be alarmed by sometimes lower blood pressures. Also, as we talked about, the heart is weakened, and some of these hormones that are activated make you retain salt and fluid, and the heart has a real time pumping out fluid out to your kidneys to urinate out, that you're prone to congestion forming. So you have to really watch how much salt and water you take in. If you go and have 5 glasses of iced tea for lunch, that's just too much to absorb through your stomach, pass through your veins up to your heart and get out, and you can go into congestion. Non-steroidals are a problem with heart failure. Non-steroidals are great at treating pain, but they are big vasoconstrictors of the blood vessels in your heart and in your kidneys. And we know that if you're taking non-steroidals on a daily basis, it increases your chance of dying of heart failure. So we talk to patients about working with their rheumatologist and their pain clinics and their primary care doctors about getting them off of non-steroidals. You know, if you have a gout of flare and you need to take a non-steroidal for 3 or 4 days to get rid of the gout, that's the only thing that can do, that's okay. But really, daily non-steroidals is strongly discouraged and been shown to be adverse. Minimizing alcohol consumption is important. We talk about anemia. If you have anemia and you have heart failure, that's a big double whammy. And so we really work with people and their primary care doctor on correcting their anemia. And then something as simple as immunizations. We know that just as the COVID experience has told us, if you get the flu, somebody with heart failure just doesn't have the reserve to fight the flu as well as somebody who doesn't have any heart weakening, and sort of a respiratory illness can quickly become very dangerous. Weight loss is important also. There's a strong correlation between obesity and developing heart failure. And I'll let for sort of, so we have some time to finish up with some questions, some of the slides there, 41 through 46 deal with that. So I want to just finish with maybe 4 or 5 slides. There's a question about exercise with heart failure. Can I exercise if my heart is weak? And the answer is a definitive yes. It's been studied. They did a study where they took people and sort of said, you know, you can do whatever you want, including sitting on the couch, or really go out and 4 or 5 times a week exercise to what your brain and heart says is moderate exercise for 30 minutes. And the people who do something like that have less chance of dying of heart failure or being hospitalized with heart failure. So we really encourage our patients to exercise. What we don't want you to do is redline it to exhaustion and come home and fall on the couch and take a 4-hour nap. You do have a slightly injured organ and you don't want to do that, but moderate exercise almost on a daily basis is highly recommended and safe. And then I guess lastly is sort of understanding polypharmacy. As we talked about, there are probably 3 or 4 hormones that are activated when your heart gets weakened. And unfortunately, we don't have that magic bullet, one pill that fixes everything. So you're going to have to take about 4 to 7 medicines. And most of them, luckily, are generic. They cost about $4 to $10, but there's probably 2 of them out there that are new that could be more. And it's understanding why you have to take that makes it a little bit easier to go to the pharmacy and get them. And then really learning to take your weight compulsively. I say weight is sort of a vital sign for my heart failure patients. They weigh themselves every day. So going down to slide 51 to summarize, as Liana talked about, heart failure is when the heart's not strong enough to pump blood to keep the metabolic needs of the heart going, of the body going. It's unfortunately very common. About 1 in 5 people will get it, and it's a very costly disease for U.S. healthcare. The symptoms are many and they're vague. They can be short of breath, swelling, and fatigue are the most common. And I would say an echocardiogram is the most important test to evaluate and confirm. And if you really think you might have heart failure, sort of demand from your doctor to get an echo. On slide 54, the second summary slide, the good news is it's not an irreversible disease anymore. Since the early 1990s, many medicines and pacemakers have been developed that make this a chronic, tolerable disease where the heart can get stronger. Early detection of the heart failure portends to the best chance of recovery and a good prognosis, and that there are a lot of lifestyle modifications that need to be done. Moderate exercise, salt and water restrictions, adherence to a complex polypharmacy, you got to stop smoking and keep up with your vaccinations. And we didn't go, but on the slide, if you have a heart failure clinic in your community, try to get in and be seen, even for just a one-time visit to confirm you're on the right medicines. But a lot of education can be done and really getting access to the best of medicines. And a thank you for your patience and thank you very much. Liana, how about I'll have you come up and we've got about 5 minutes to take any more questions.
And we can extend to like 8:10, 8:15 to
Okay.
accommodate questions. I got to take this back.
Sure.
If that's okay.
'Cause you're
So I can
probably
read all our questions. So we do apologize. We just, our monitors in this room went out, and then now we've got all kinds of hospital sounds happening. And so good. Okay. Oh, good. Someone said the slides were easy to follow. That's great. Okay, so your slides are easy to follow. Thank you very much. And our first question. If your diet is plant-based, if your diet is plant-based and you exercise 70% of your maximum heart rate with at least 70 to 75 minutes a week, but have familial high LDL, should you consider a statin?
Well, this was a talk on heart failure, so I think we're getting into a little different thing, but I think we're finding out more and more that a plant-based diet is a very healthy diet to be on. And exercise actually can bring down your cholesterol. It really all depends on how severe your familial hyperlipidemia is. And if you have your age and other medical problems and stuff. There are unfortunately some people that can live the perfect lifestyle, but just something that a genetic enzyme deficiency makes it hard for their body to metabolize and process. And in some of those people, we do put on a statin. But I think it's not one or the other. It's really both a very healthy lifestyle, which we are lucky in our community to have. But in some people, that's not enough, and that's when we use statins. I can't say a yes or no. It's a very sort of gray question.
I see. Is exercise what keeps your heart flexible as you age?
I think
Just,
probably yes. There are many wonderful benefits of exercise. Some of them a little bit too deep to go into, from nitric oxide expression and stuff. But I would say exercise helps keep the heart safe, healthy.
do all of the 4 to 5 symptoms appear together, or is it symptomatic of heart failure if a person has 2 or 3 of the symptoms?
So I think there's a slide that I didn't put in this one, but no, each of them are a little different. I would say fatigue and shortness of breath are the most common, happening in maybe about 60% of people. Swelling in your legs, about 40%. They all can happen, and in some people, all 5 of them do. Some people, it's just one. But I think what we're saying is there's the cases that we see, unfortunately, 3 or 4 times, both Liana and I, where somebody was on an antibiotic for a respiratory infection and it just didn't get better. And after 4 rounds of antibiotics, they did a chest x-ray, which showed the heart had gotten real big and had water in the lungs. And they did a BNP level, which was way elevated. And we weren't treating an infection, we were treating heart failure. So getting back to it can be any of the 5. It can sometimes be all 5 of those. But if you're not getting better and you have any of those 5 symptoms, I would sort of ask, could this be heart failure?
Are migraine meds a concern if they are vasoconstrictors?
Take that. All right. Vasoconstrictors, and I was talking about non-steroidals, are not helpful. Vasoconstrictors are hard on the heart, but they're also wonderful on treating other things like migraines. I would sort of, I think it's a case-by-case basis. Migraine medicines haven't been studied as much as non-steroidals. Non-steroidals have really been studied in heart failure and need to be avoided. That's not the case with migraine medicines. Some people with very tenuous blood flow in their heart, lots of stents or bypasses and heart weakening, it might be a risk and you'd have to talk with a neurologist, but I don't think you can make a blanket statement one way or the other with migraine medicines.
What do you mean about water limitation? My challenge is not drinking enough water, I thought.
Well, in Colorado, at high altitude where everybody gets dehydrated and kidney stones are an issue, 95% of the time we recommend drink, hydrate. But in heart failure patients, that sometimes is the opposite. We know that unlimited fluids, your body and your heart in particular, has to be strong enough to mobilize that fluid. And so for heart failure patients, we talk about 70 ounces of fluid in a day, which if you have sort of an 8-ounce glass, about 8 or 9 of those a day. But people who have unlimited salt and water intake can get into problems with it going into the lungs and the legs. So usually about a 70-ounce fluid restriction a day for a heart failure patient is one of the things we talk about.
I hope this is okay to ask. I don't quite understand it, so I'm going to ask it. Can you address K2, MK7, and taking D3 to rid calcium from the arteries?
I'm not an expert on that, so I'm going to have to defer on that.
Okay, that's fine. All righty then. This guest asked, and we've been a little herky-jerky tonight, but she said, did I miss the definition of heart failure? I have high blood pressure and a couple of leaky valves. I thought it was called coronary artery disease, but didn't know if this is a category of heart failure. I'm very slim, so weight is not an issue for me, and I exercise moderately.
We spoke about the definition of heart failure kind of throughout this, but at the beginning of the program here. So it's basically that left ventricle, the main pumping chamber of the heart, not functioning well. So that pumping action of the heart is weakened or compromised in some way. And so you're not able to push blood forward out of your heart to the rest of your body and not able to meet, your organs and the metabolic needs that your body demands because of that decreased pumping action of the heart muscle. So coronary artery disease can contribute to weakening of the heart, but that more applies to disease within the arteries that feed the heart muscle, feed that left ventricle, and keep that left ventricle strong. So if the blood supply is compromised, that's when you can have heart failure as a result of coronary artery disease.
I think in Liana's slide, one of the first ones, if you go to a textbook of cardiology, heart failure is something, whatever, and it's about 40 different things that make the heart not strong enough to pump the metabolic needs of the body. Coronary disease and hypertension are the two most common. What people then incorrectly say, well, then if I have coronary disease, I must have heart failure. That's not the case. There are people that have hypertension and coronary disease that their heart is strong. But if it gets out of control, it can make the heart get weaker.